Hello everyone, welcome to EAU Podcast. My name is Alon van Uitert and this is Hoen. And we both are members of the EAU Guideline Panel for Paediatric Urology. As you may know, the Paediatric Urology Guideline consists of 26 subchapters. So each year we try to update about 5 or 6. And this year we updated 6 chapters and we would like to tell you a little bit more about that. So Lisette, maybe you can start with telling us what we updated about perioperative management.
Yes, so we have updated the perioperative management chapter, and I think it's important to discuss the fact that in children it is different than in adults if you consider fasting. So in children there is a risk of hyponatremia, and it is important that we allow our children to drink up until surgery, but then again, it's still 6 hours of fasting.
And how is that with breast milk and milk? Can you tell us a little bit more about that?
Indeed, there is a difference. So breast milk is up until 4 hours prior to surgery, while normal milk or formula is 6 hours till surgery.
Yeah. Thank you.
With the children, we also consider the ERAS protocol, to have an enhanced recovery after surgery, which has been insulated in children much more in the last decades.
Okay.
And what is different from adults, but I think also very important to highlight, is that we have the preventative measures for anxiety. So we have the...
I can imagine that is for children, that is quite something to undergo surgery.
Yeah. So we use virtual reality goggles or even, but also some medication in order to make anxiety as low as possible.
Oh, yeah.
Yeah. Can you tell us a bit more about the next chapter?
Yes, the next chapter was about hydrocele, which is a very common pathology that we see in the clinic. And actually there was not that much changed because the practice of hydrocele is well established. The only thing that was added was the abdominal scrotal hydrocele, which is quite a different entity, that the hydrocele goes up into the abdominal cavity.
And what has changed?
Well, it's changed that, the practice used to be that you have to resect the whole hydrocele. But that is quite an extensive surgery to do intra-abdominally. So what is changed is that it's now more advised to do it a little bit more conservative. And do the surgery more for the scrotal part, but not do an extensive surgery intra-abdominally, because you can get problems with that, and maybe it's not necessary.
And what kind of problems do we encounter?
Well, you can get because it's a large wound, you can get a higher risk of bleeding, higher risk of edema, and well, if you can avoid that, I think that is something we should do.
Yeah.
Yes.
Yeah, definitely.
Well, the next subchapter that we updated this year was about minimally invasive surgery. Well, that is something that is hot and happening also in the pediatric field. Can you tell us a little bit more about that?
Yeah. So we see that robotic surgery is up and coming. It's been gaining in popularity definitely the last decade. We did not alter that much in like the content of the chapter. However, I think it's always important to highlight that it is necessary to have an open access, so that you have a good visual and you do not have any risk of bowel damage, and that we should always consider that a child is different than an adult. Try to use as low pressures as possible to avoid any risk of cardiac or pulmonary.
Yes, so a child is not a small adult.
Exactly.
The physiology of the child is different.
Yeah,
yes,
it is.
Especially in laparoscopy, I can imagine that is important.
Yeah.
And are there many studies published right now in minimally invasive surgery, robotic surgery in children?
There are a lot of studies published. However, they are very consistent over the last year. So no updates for the chapter, but definitely. So we talked about 6 chapters that we've revised.
Yes.
I think the next one was trauma.
Yes. So, we actually adapted that chapter a bit because we thought it would be good also for the general urologist to have some support in acute care for children.
Yeah, because that's different.
That's different. There are several pathologies in children that need urgent treatment. So we made a new chapter which is called Emergencies in Pediatric Urology. And this chapter entails a few things that we did not change. For instance, the acute scrotum chapter we did not update, but it is a part of the emergencies chapter.
Yeah.
What we did change was the trauma section because, renal trauma is common in children because of the different anatomy that they have.
Indeed. And can you explain a bit more?
Well, in the child, the kidney is located a little bit lower, and it's less protected by the rib cage. You have less fat around the kidney, so when you get a blunt abdominal trauma, the risk of injury of the kidney is higher.
Yeah.
And what we think is very important is that when there is a major trauma, abdominal trauma in a child, that you do a good staging, and that staging needs to be done by a CT scan, and preferably a 3-phase CT scan with an arterial phase, a venous phase, and a delayed phase.
Indeed, yeah.
And the reason is also for this delayed phase that it's very important to see if you have urine leakage, to give a good grading of the renal trauma, because if you have urine leakage, you have higher chance of complication.
Indeed, yeah.
The question that often arises is, if you see urine leakage, should you drain? Should you place a double J stent? Should you place a nephrostomy tube? But actually there are some new studies that show that doing that while the child is asymptomatic is not of extra value. Yeah. That you only should do interventions if the child is symptomatic.
Yeah, it might even make an infection happen.
Yes, you can introduce an infection. Yeah, that is true. And you do an extra procedure with an anesthesia in a child, because all these kind of procedures you have to do under general anesthesia.
Yeah.
And what I think is also a little bit changed is that in the follow-up of a renal trauma, there used to be very conservative, like you have to do a routine CT scan or ultrasound after a few days to see what's going on. And I think many of us still do that, but there was a very nice study that showed that routine imaging actually does not prevent and change the course.
Yeah.
So maybe if the child is asymptomatic and doing well, you don't need to do a routine ultrasound check just to see what's going on.
Yeah, which makes it less burdensome for the child.
Yes.
Because everything that we do with children
is a burden.
Is a burden.
Yes.
And that's something that we need to consider. Yeah.
What we did next is because when you look at acute care, priapism is also a pathology that can happen in children. It's rare, it's true, but also it happens several times a year in the Netherlands or in Europe as well.
And it might be something that if an adult urologist is confronted with it, he doesn't know how to deal with it.
Exactly.
So important to give him some guidelines. Exactly,
because the adult urologist will think, oh, okay, this is a priapism, but it's a child. What is different? Mm-hmm. And I think if you look at priapism, there are several things that are different. Most importantly is the etiology. Yeah. Because most of the children with priapism have a sickle cell disease or a thrombopathy. So this you have to take into account also in your analysis, and you have to get a hematologist involved when a child presents with a priapism.
Yeah, because it's a different treatment that we do when it's a sickle cell, for example.
Yes, that is, and it's very important to know if a child has sickle cell disease because that also gives greater risks when you do a surgery or when you do the treatment. What also is different, I think, in children is that everything you do, you have to do under anesthesia or with sedation. So the normal treatment in adults is that you do a blood gas to see if it's an ischemic or non-ischemic priapism. That is in a child more difficult because you have to do that with anesthesia. So that's why we would recommend, if you have it available, to perform a color Doppler ultrasound first to distinguish between the ischemic and non-ischemic priapism, because it's a different entity. An ischemic priapism is acute. You have to make sure the blood flow is
Restored,
better, restored to the penis, while a non-ischemic, a high flow priapism is not.
Yeah. Of course, you have a time slot.
Yes, you have to
Time
do it
matters.
within a few hours.
Yeah.
You have to make sure that the blood flow is reestablished to the penis. Very shortly, it's even more rare, is a neonatal priapism, which happens sometimes when a baby is born. He has a priapism. Well, actually, that is not an acute problem. It can cause quite some disturbance, but it usually resolves by itself.
Yeah,
so that's good to know.
obviously.
Well, I think that's enough about the trauma chapter and the emergencies chapter. Maybe you can tell us a little bit more about the Cluto chapter that we have.
Yeah, so we have the congenital lower urinary tract obstruction, which is, of course, something in which we discuss mainly posterior urethral valves. Again, not much has changed. We know how to handle it. It's important that you have the antenatal diagnosis and that you confirm that when the child is born.
Yeah.
I think it's important that you consider the renal function, so get the pediatric nephrologist involved. But other than that, we have no new literature on how to deal with it.
Is Cluto lifelong care?
It is. It's
why is that?
important to follow them up because a lot of these patients, like 1/3, end up with end-stage renal disease. So definitely something to consider. And to have a close monitoring of it.
And what about their bladder function?
Bladder function is, of course, also a problem in a majority of the boys. We see in the first stage, you see an overactive bladder, but during the follow-up, it could resolve into an underactive bladder or so much overactive that a bladder augmentation might be necessary. Yeah. So indeed, very important to follow it up.
And that's what you call like a valve bladder.
A valve bladder, indeed,
yes.
Indeed. And there have been studies to show that with medication you might delay the valve bladder deteriorating. So use of anticholinergics and even alpha blockers to make the outflow more easy. But again, that was not new in the chapter.
No.
So
no, and I think it's not generally recommended within all patients, right?
No. It's personalized care. Yeah, it is. Yeah.
Okay. And can you tell us a little bit about fertility preservation?
Yeah, that is of course a hot topic because this is a field in medicine that is evolving. So for girls, oocyte preservation is being more and more commonly to do.
And can you quickly describe what is oocyte preservation? What? Because I don't know if everybody knows.
So what you do is that you, before you start medical treatment, like chemotherapy, for example, is that you harvest the oocytes and then preserve them through cryopreservation.
Okay.
In boys, especially pubertal boys, we can do, of course, sperm cryopreservation. In pre-pubertal boys, that is still a very experimental field. So some centers do this preservation, but it's still unclear if the preservation of these pre-gonal is usable in the future. So experimental still. However,
Can you maybe, are there other things you can do to protect the boys?
Yeah, indeed.
The little boys of the boys.
The little boys of the boys, yeah. So one of the things that you could do is you do gonadal preventive measures.
Okay.
So if you have radiation in the scrotal field, it might be possible to temporarily put the testes in the inguinal area.
To get them out of the
radiation field.
Yeah. Oh,
yeah.
wow.
So it's at least important to consider if it's possible and know that there are options. So we describe them in the chapter. So when you're encountered, you can read it. Yeah.
Excellent.
I think that were all the chapters that we have there. Yeah.
But we did write also a new chapter, or at least it's being written, I think, right now about transition.
Indeed. So for the future.
Yes. So
coming updates.
Because of even the little ones eventually get older, and many pathologies that children have during childhood, they also transition into adulthood. And so we thought as a panel that it would be very valuable to also aid the urologists in this part, because can you tell us a little bit what patients are transitioning, what patients the adult urologist can encounter?
So we have, of course, the neurogenic patients.
Yes.
They are patients from the day they are born with us. And initially, we have a very close follow-up. And when they get stable, they get a less intense follow-up with us, but we still follow them up until they're 18. And there are some specific considerations with these children. Quite a lot of them get a bladder augmentation. And when you have a bladder augmentation, there are some risks that you need to consider. So is it that they still do catheterization through their native urethra?
Yeah.
But it could also be that we have put in a continent stone.
Catheterizable channel.
Indeed.
Yes.
Yeah. And these stomas have some complications that are considerable.
Yes.
More than half of them get a complication, and usually it's a minor complication, but it's still something that we need to be aware of. And it's good to have a urologist that knows how to deal with it.
Yes.
Also, of course, if you have a bladder augmentation, there's a risk of cancer in the bladder. So an intense follow-up with cystoscopies after 10 years after bladder augmentation is important.
Yes. Yes.
Yeah.
And sexuality, is this also something that is described in this chapter?
Yes, that is. Yeah. It's
also very important, especially in the transitional phase.
Definitely.
Yes.
There have been several studies that have shown that patients feel a lack of attention for their sexuality. And we have also studies that the urologists feel that they don't know how to talk about it. So that's a discrepancy.
Yes.
And I think it's important that with the transitional chapter, we highlight that the urologist needs to take the lead, at least in addressing it.
Yes.
Asking about it, getting the attention.
Yeah, because the patient has an unmet need and we don't know how to fulfill that need.
Indeed.
So
and this provides you handles to,
Wow, that's great.
Yeah.
Okay. Well, we did a very, very small update to the reflux chapter as well.
Indeed.
But that was based on a very nice study, I think.
Yes. The PREDICT study by Morello. It was published in New England Journal of Medicine.
Well, that is big for
pediatric
urology. That doesn't happen that often.
That was why we added an update,
of
indeed.
Course, yeah.
Morello et al., they looked at antibiotic prophylaxis in children with vesico-urethral reflux, grade 3, 4, and 5.
Yeah.
And they show that it has a significant decrease in urinary tract infections. So indeed, we updated that chapter and also made a publication in European Urology.
About the update, right?
About the update, indeed.
So the main conclusion is that continuous antibiotic prophylaxis, which is always a topic of debate.
Indeed.
But in the higher grades of reflux, it is recommended.
It is, definitely.
It gives a small benefit.
It's established. Yeah, it's small, but it's a significant benefit without any additional harms, which is also very important to consider.
Yeah. Because it's a low-dose antibiotic.
Indeed, yeah.
Okay. So what is next for the guideline? What else are we working on? Maybe you can tell a little bit about it.
Yeah. So we are doing podcasts like we are doing now.
Very nice.
Usually not with us on video.
It's a non-video podcast, right?
Yeah.
About different topics of pediatric urology.
Yeah. We are working in close collaboration with the ESPU, which is the European Society for Paediatric Urology, which is also part of our guidelines, to do webinars to highlight topics.
Maybe to highlight that the name of our guideline was changed again. It was the EAU guideline panel, now it's the EAU ESPU guideline panel.
Indeed.
Which I think is a very nice development again.
Yeah, very nice. So that's good that we have this collaboration firmly established.
Yes. Yeah. Yes. And also, I can add maybe that we are working together with the ERN, the European Reference Network.
Indeed.
There is a collaboration to make a very extensive guideline about the neurogenic bladder. And I think this guideline is almost finished, and it will be in May, June. It will be published,
indeed.
something like that.
Yeah.
So
we have the other specialists involved as well. So the pediatric neurologists, the rehabilitation specialists.
But also patient advocates.
And also patient advocates, which is a very nice touch.
And I think it's pretty unique in this phase of guideline development.
Yeah, indeed.
Okay.
So we're very busy as the Pediatric Urology Guidelines panel.
Many, and next to these things we discussed, many reviews also being performed, clinical questions that we try to answer. So that is something we hope to work on more in 2024.
Yeah.
So thank you for watching EAU Podcast. You can, of course, subscribe to this. In summary, we discussed the update that we did on 7 chapters this year. We described the relevant collaborations, and we hope to talk to you soon again.